medical grand rounds. Just before we get started, just a reminder to please enter your questions at the end of the presentation. If you can enter your questions in the chat, please, that would be greatly appreciated. And also just a quick reminder to let us know that you were present today by answering a very brief survey that will be sent to you at the end of grand rounds. Our rounds today are brought to us courtesy of the Division of Radiation Oncology, and I'd like to ask our Chief of Radiation Oncology, Dr. Tarek Hijal, to present our speaker today. Tarek, the floor is yours.
Thank you very much, Dr. Janetti. So it's my pleasure today to introduce Dr. Sonia Skamene, a radiation oncologist here at the MUHC and assistant professor of oncology at McGill. Dr. Skamene trained at McGill University and then went for fellowship training in Boston at Dana-Farber Cancer Institute, where she trained in palliative radiotherapy, which is today, like the title suggests, a subspecialty of radiation oncology. She also has a master's in quality improvement. And I think today you'll be able to see how she was able to bring those two things together. Not only will be presenting about how palliative radiotherapy has become more than just treating symptoms. The field has progressed a lot, but she'll also present what we've been trying to do in radiation oncology to improve the care of patients with metastatic disease at the MUHC who are sometimes undertreated with radiation. Thank you very much, Dr. Skamene, and the floor is yours.
Okay, thank you very much for that introduction and also for having me participate and present today at Grand Rounds. I'm very happy to be here. As you've heard, I'm going to be talking about palliative radiotherapy. I have no disclosures. Here are my objectives. I just wanted to start by reflecting a little bit on how radiation oncology has recently been included under the Department of Medicine. This has not always been the case. And my father, a retired endocrinologist, is finally so happy that I'm affiliated with internal medicine and has gotten over his disappointment of my not following in his footsteps. I trained at McGill University, as you heard, and I remember a particular quote by Dr. Lawrence Green, who many of you will know, when I was rotating at the Montreal General in my first year. And I believe he jokingly said, I always wanted to study radiation oncology, but I never had a weekend to spare. I can confirm that after studying from my Royal College that Dr. Green knows absolutely nothing about radiation oncology. And so I'm happy to be here to shed some light for some of you. Many of you may not know my fellow colleagues in my department. We are often relegated to the basement for technical, logistical, and radiation safety reasons. But I work amongst a wonderful group of colleagues here, and you may have seen some of them on the floors or in various academic endeavors. So I just wanted to present them here. Now, when talking about radiation, some of these images might come to mind. If you don't recognize them, which would be hopeful, would be the case, is we have here the Chernobyl site, and over here the nuclear bombs in Hiroshima and Nagasaki. And these terrible disasters have profoundly contaminated not only their local environments and the people who live there, but also society's perception of radiation, which is still very pervasive today. Now, I can't give a radiation oncology talk without showing some of these faces that you see here. So these people are responsible for harnessing the power of radiation for therapeutic benefit. And this goes back to the late 1890s, where we have Wilhelm Röntgen, who discovered X-rays. And only 1 year later, we have Emil Grube, who used X-rays to treat a patient with breast cancer. That was in 1896. And Marie Curie, at around the same time, discovered radium as a natural source of radiation. And so with the help of these people and many other scientists, we were able to now use radiation for therapeutic benefits. So who is treated with radiation? We treat a wide variety of patients. We have adult and pediatric patients. We treat benign and malignant diagnoses, and this is not known to many, but we have many referrals for benign diseases such as benign brain tumors, meningiomas, craniopharyngiomas, schwannomas, as well as other pathologies, keloid scar prevention, Graves, ophthalmopathy. And so we really do get quite a variety. About 50 or 60% of patients will receive radiation therapy at some point of their cancer trajectory. So certainly not all, but the vast majority. And of those that do get radiation, about 2/3 will receive radiation with curative intent and 1/3 for palliative indications. So a lot has changed in terms of how we deliver radiation. We have two main methods of delivering radiation that I've put here on the slide. We have brachytherapy, which is actually using a radioactive source like radium that's constantly emitting radiation that can, in one instance, this is the type of setup we have here at the MUHC, where that radiation temporarily goes into catheters, which are located within a patient's body, stays there for a period of time, and then is removed. That's one way of delivering radiation, brachytherapy. But for the purposes of this talk, I'm going to be talking about external beam radiation therapy, which is the delivery of radiation using X-rays. So I have a video that obviously is not going to work. So I'll skip it. I thought, oh, wait, no, I might be able to do something with that. I saw a play button. No, not coming up for me. Ooh. No, I'll give up on that one. I was going to show you how the linear accelerator works, but I know that these embedded videos are always hit or miss. So I'll proceed right to how radiation works. So I'm going to make this as simple and straightforward as I can. So just a reminder of the electromagnetic spectrum. Radiation is a form of energy that is carried from a source that's carried by waves or particles. Photons are quantities or amounts of electromagnetic radiation and are essentially the packets of energy. X-rays consist of streams of photons that have sufficient energy to eject an electron from an atom or molecule, thereby ionizing it. So that is ionizing radiation. What happens is, as these photons travel and interact with tissue, for instance, of our bodies on our skin, those particles will interact and create these electrons. And those electrons will damage cells at the DNA level, either directly with the electron causing damage to the double helix of the DNA, or indirectly by creating free radicals that then will cause damage to DNA. So when we talk about DNA damage, we're talking about base damage, single and double strand breaks, and DNA protein crosslinks. And that all sounds very scientific, but in essence, healthy cells are able to repair this damage using base excision repair, homologous recombination, et cetera, all of these innate mechanisms. But cancer cells do not have the same capacity for repair. And so radiation preferentially damages cancer cells, which have these abnormal pathways, compared to healthy cells, which are more likely to repair the damage. We know quite a bit about the properties of the different particles that we use: photons, electrons, and more recently protons, which we do not have here in Canada, which I won't discuss further. And so understanding these properties, we understand how these molecules interact in tissue and cause damage, and then we can have an anticipated impact of our treatment. Like any drug, radiation, when there's too little, there is not enough effect, and when there's too much, there is potential toxicity. So the goal of the field of radiation is to achieve tumor control or symptomatic improvement with the minimal possible acceptable risk. And so when I'm talking about that, it's the therapeutic ratio that we see in drugs, but this also equally applies to radiation. We try to find that balance between achieving tumor control while avoiding complication, which typically is a matter of dose. Now, when we're talking about curative intent radiotherapy, we accept a certain amount of risk because we're aiming for cure or eradication of a disease. And so When we think about palliative radiotherapy, we need to have different levels of what is acceptable. This is a very nice quote from the 1960s, which I think still very much applies today. When the object of radiation therapy is palliation, new ground rules must be applied. We no longer accept serious complications or even slowly self-limiting side effects. We must maximize quality of life of patients, minimize treatment time, cost, and convenience need to be taken into account. Now, many of you in internal medicine will have had experience referring patients to radiotherapy. And probably the most common reason of indication for a referral with a patient with malignancy is for pain. Pain most commonly comes from bone metastasis, which is one of the most common referrals that we have for palliative radiotherapy. But there are many indications. Pain can come not only from bone metastases, but also from lymph node masses, large tumors, either primary or metastatic tumors. There's neurological symptoms, brain metastases, nerve compression, such as cord compression or cauda compression. There's also nerve root compression that can be extremely cause a very high symptom burden. Bleeding from various organ systems. We get many referrals for hemoptysis, from bleeding lung tumors, from the GI tract, such as in the esophagus or in the stomach, from the bladder, from gynae malignancies. So this is also a common indication for palliative radiotherapy. Radiation can be very effective for respiratory symptoms caused by masses in lungs, the head and neck region, or the esophagus. Obstructive symptoms from organ outlet obstruction, from compression of vascular structures or the airways. And then another indication that we commonly see is after an intervention, such as spinal stabilization and decompression for cord compression, or after surgical fixation of a long bone containing a bone metastasis. So these patients are frequently referred to us for palliative radiotherapy in the aftermath to improve symptoms and prevent recurrence. There is also some debate about the utility of prophylactic palliative radiation for impending fractures or spinal cord or cauda compression, but this is not entirely clear at this time. So I would say that these are the main indications for palliative radiotherapy and well established in our field. I just want to mention bone metastasis. As I said, this is one of the most common referrals we get. Most commonly, they are from breast, prostate, and lung cancers, which also have a very high incidence. They can cause very significant symptoms related to skeletal-related events, pain, cord compression, fracture, and even hypercalcemia. We do need to take into account certain characteristics of bone metastases, like if they're lytic or blastic or complicated versus uncomplicated. But in general, radiation is extremely effective for palliation of pain. Multiple meta-analyses have been done that even a single treatment results in low 70% overall response rate and a nearly 30% complete response rate. Now, I know a lot of people want to know about what are the toxicities associated with palliative radiation, and it's always challenging to talk about toxicities in general terms because all toxicities, like for drugs, are related to the dose of radiation that we give. And in radiation, because it's a focal treatment, it's also very pertinent to where we're giving that radiation. And so taking into account the total dose that we're giving and where we're giving it, the side effects can have a very vast range. These are my generalities. I would say fatigue is one of the more common side effects of any palliative radiotherapy course. It can happen no matter where we give radiation. It typically lasts a few days. Sometimes it can be significantly longer. Anytime there's skin in the field of radiation, there's risk for reddening of the skin, inflammation, irritation, even disclamation, like peeling after a sunburn, that type of appearance, loss of hair. In the brain, we're particularly concerned about the neurocognitive impacts that can come months to years after radiation. We can have symptoms in the eyes like cataracts. In the head and neck region, the main concerns are mucositis and dry mouth. Depending on the dose, many of these side effects can be short-lived. Some of them can in fact be permanent. In the lungs, our main concern is pneumonitis. In the esophagus, stomach, vomiting, nausea, dyspepsia, esophagitis, small intestines, diarrhea, nausea, vomiting again, bladder, irritation, dysuria, frequency, urgency, bone, pain flare, fracture. I mean, so you can see this is like a very long list. We would never counsel a patient on this entire list because we're never giving in a palliative setting, or I would say very, very rarely, a total body radiation. So what the patient is going to experience after palliative radiotherapy is going to be fairly limited to the area of the body that is going to be radiated. And then we can talk about which parts of this list will pertain. Now, what can we do about these palliative toxicities? You know, the goal of a palliative treatment is not to cause toxicity. So what are we doing about it? So certain things we can prophylax against. Pain flare, which can occur about 1/4 to 1/3 of the time after we treat a bone metastasis. That means a few day worsening of the pain before it levels off and then improves, hopefully with an effective treatment, can sometimes be mitigated by a prescription of a short course of Decadron. We also sometimes prophylax any inflammation that can be caused by treatment of brain metastases with Decadron. And sometimes for neurocognition, we'll even prescribe certain medications that are used in dementia, like memantine, that may preserve some aspect of neurocognition at long term. But for the vast majority of other toxicities, we can only really provide supportive care and hope that the symptoms resolve as quickly as possible and don't leave any long-lasting detriment. When we talk about the goals of palliative radiation, our main objective is to improve quality of life. And so we're doing that by reducing symptom burden, improving functional status, minimizing toxicity, and minimizing time spent in the hospital. That could mean as an inpatient. It could also mean minimizing visits to the hospital. And with these goals in mind, many strategies have been implemented in our field to promote these goals and values, even in the past decade. And that's what I'm going to focus on here. Those of you that have referred patients for radiation for brain metastases might be familiar with these types of images, or might not even know what we're really doing in palliating of brain metastases. But what you're looking at here is the treatment of the whole brain, which historically was the best treatment available when a patient had multiple metastases in the brain. Now, even though there are probably a quantifiable number of metastases, our approach has been to treat the entire brain because there might be more disease than we can see on a CT scan. And our approach was to treat not only the visible sites of metastases, but any potential or future developing metastases that might be in between those lesions. And so this is a classic whole brain radiation field. You can see that the entire brain and even some of the neighboring tissues are all getting the same dose of radiation. Now, a very important publication came out in 2016, which reflected a lot about what people thought about whole brain radiation already in the field of radiation oncology, which is that for patients with advanced disease, highly symptomatic, that giving whole brain radiotherapy versus best supportive care with steroids resulted in very similar overall survival, quality of life, and use of steroids. Now, going back to these whole brain fields, there is quite a significant amount of toxicity associated with this type of radiation. Patients lose their hair, and there is a significant fatigue, some nausea and vomiting that may accompany treatment. I would say that's less typical, but most significantly would be an impact on neurocognition, which typically manifests as changes in attention, concentration, and short-term memory that can present typically months after radiation. And so when we see the results of a study like this, it makes us wonder, is it truly worthwhile to offer patients with multiple metastases whole brain radiation? Now, there are many criticisms to this study to say that we do still use whole brain radiation, but we're very fortunate that technology has advanced so that we're able to use different methods of treating brain metastases. This is one of the most important evolutions in palliative radiotherapy in the last 2 decades, which is the use of stereotactic radiosurgery. So instead of treating the whole brain, when we see a small lesion in the brain, we can target just that area with a very high dose of radiation with the intention of completely killing off or ablating the tumor cells in that volume. Now, depending on the size of the lesion, we can often give this treatment in a single day. We can give it to multiple lesions. There's currently a study open for 5 to 15 lesions at once to receive high-dose radiotherapy. And this treatment is associated with much less toxicity as compared to whole brain radiotherapy, particularly when it comes to neurocognitive endpoints. Now, the way we're able to give such high doses to such a small area is that these areas are, in fact, very small. They only need to receive very few treatments, and we need quite advanced technology in order to pull this off. For patients that are not eligible for stereotactic radiosurgery, maybe by nature of large size of lesions, or they have too many for it to be feasible, we've also evolved ways to minimize neurocognition by sparing the hippocampi, which is an area of the brain that is thought to contribute heavily to some of the neurocognitive endpoints that we see in radiation. And so we even have ways now to treat the brain while reducing the dose to those hippocampi when feasible, with the aim of limiting neurocognitive impacts further down the road. Now, as I said, this has been made possible by some of the technological advances that we have. You can see here the CyberKnife, which is a machine that we use in radiation. This is a linear accelerator, but instead of being mounted to the floor here with a head that revolves around the patient, this is a robotic arm that can approach a patient's tumor from many different angles, allowing us to be able to give higher doses to very small targets with minimal toxicity to surrounding structures. You may have also heard about a gamma knife, which is another machine similar to this one, which is used only for the brain. The advantage of CyberKnife is we can use it in other organs other than the brain. Now, another adaptation that we've made in palliative radiotherapy is to change our dose conformality. What you're looking at here is what we call APPA fields. And this is historically how we treated the vast majority of spinal metastases. Our target when patient has a brain met in the spine is right here in the vertebral body, okay, or in its surroundings. But when we used APPA fields, you're getting one field from the front of the patient, one field from the back, and everything in the path of those fields is receiving the same dose of radiation. Now, this has been established for decades to be safe and very well tolerated, but that still means that patients will have some toxicity, most notably in the form of GI toxicity. As you can see, there's a substantial amount of intestines and sometimes the stomach that can be treated in a low thoracic or lumbar field. In the thoracic region, it would mostly be in the heart. And so because of that, we've used our technology. Can we limit the dose to those more anterior structures and focus only on the vertebral body or the area that we want to treat? And the truth is that we can. And I would say 5 years ago, 10 years ago, most of our treatments looked like this. And now most of our treatments, when we have time, look like this, okay? So we're able to really concentrate the higher doses of radiation that we want to give for palliation just to the areas where we want to give it. And this has been found in randomized control trials to improve quality of life. There is very little data available. It's amazing that we have this data. And this is a publication from Quebec, from CHUM, actually. Another way, of course, that we can mitigate any toxicities from radiation in the realm of palliative radiotherapy is to reduce the dose. And we typically give the lowest possible dose to achieve some degree of symptomatic improvement or tumor control, if that's what we're going for. And bone mets, where we use 8 gray in a single fraction for uncomplicated bone metastases, seems to be as low as we can go. There have been randomized studies looking at doses lower than that don't achieve the same benefit. We have had, though, some very impressive success in palliation in low-grade non-Hodgkin lymphomas. You can see an image here of a MALT lymphoma, where it's not uncommon to involve the orbit. And these tumors can respond to doses as low as 4 gray in 2 fractions, which is accompanied by minimal, if any, side effects. And this low dose achieves a progression-free survival of 70% at 5 years, which in the setting of palliation might be very acceptable as compared to a higher dose, which may achieve a better outcome, but would be accompanied by much higher toxicity. So of course, this is ways to reduce the dose has of course been explored. Now going back to bone metastases, the data supporting the use of single fraction or single treatment with radiation has been so impressive that it's spurned some choosing wisely campaigns. In the United States and some other areas of the world, it's been very challenging to convince physicians to accept this lower dose of 8 gray in a single fraction when the dogma has been to give much longer courses of radiation. 30 gray in 10 fractions, that means 10 visits to the hospital for a simple bone metastasis or more, is very commonplace in the United States. And so their Choosing Wisely campaign interestingly focuses on not using anything more than 10 fractions, whereas the Canadian Choosing Wisely campaign doesn't recommend more than a single fraction of palliative radiation for an uncomplicated painful bone metastasis. I also want to emphasize that in radiation oncology, and particularly in this discipline of palliative radiation oncology, there is a heavy emphasis on palliative care. The ASCO clinical practice guidelines for standard oncology care identify that oncologists, and in that I'm including radiation oncologists, are providing primary palliative cancer care. We directly provide symptom management. We explore or clarify prognosis of goals of care during our visits. I'm sure not to the degree that the palliative care physicians or emergency room physicians would like us to, but we definitely have a role here. And we assess coping supports and coordinate care with other services when needed. And another Choosing Wisely campaign has identified that goals of care need to be addressed and consider palliative care referral in patients where we're offering non-curative radiation therapy. It's been well established that early integration of palliative care in patients with advanced illness is highly beneficial for patients. And so we definitely are common referrers to palliative care ourselves. This was a very interesting study that looked at consecutive patients that were referred for palliative radiotherapy. And I think it's important for us to reflect on the types of patients that we're seeing. We see 20% of patients with a new diagnosis of advanced malignancy. And this can be very pertinent is because we tend to be very efficient at booking patients in our clinic. And so we often see patients when their pathology has not yet been made available, for instance, after a biopsy or a surgery, if they're highly symptomatic, they have not yet met a medical oncologist. They may have only met emergency room physicians and surgeons. And it's often our role to explain a new diagnosis and explain our limited role in the management of their symptoms while not being able to give them a definitive plan for later on. And so this is a very important part of our practice and can be quite significant and heavy in terms of our palliative role. We often see a lot of patients on their way to, this is American study, so hospice. So in our cases, patients are not always designated as a hospice patient, but on their way to end-of-life care when no other systemic therapy treatments are available to them. And so this is very important for us to consider not only the patient's goals of care, but is the patient going to live long enough to have benefits from radiation treatment? Is it worth it? Is coming to the hospital for X number of visits going to be justified? And I want to touch on something which I might come back to later, but I think is important for many of you who work on the wards and are seeing patients in the emergency room and maybe often are pushing for urgent radiation treatment. The benefits of radiation typically occur minimum 1 week up to 2 weeks, sometimes even 3 weeks after a course of palliative radiotherapy. When it comes to pain or shrinkage of a mass, that typically can take weeks to have an improvement. When it comes to bleeding, those impacts can be much sooner within the span of 12 to 24 hours. So when we think about patients who are being transitioned to an end-of-life care, we want to make sure that a patient is going to live the 2 to 4 weeks to even have the benefit from radiation. And typically, about 50% to 70% of our patients are referred to us during the course of their ongoing cancer care. And there are quite heavy palliative care needs in these patients, coordination of care, the physical symptoms, goals of care. And so these are patients that we're seeing in our clinic, and we're handling these types of issues. I want to transition now to the evolution a little bit in the field of oncology that's been ongoing for the last 10 to 20 years, which is the definition of an oligometastatic state. Historically, we thought of cancer as an all or nothing dichotomy. So a patient had a curative disease, or they had metastases and were therefore incurable. This model is starting to shift, and metastases are thought to be more on a spectrum. Oligometastases occurs as an intermediate state between a localized cancer and a widespread metastatic disease. What does that mean? It means that we might be able to intervene with local therapies, spot treating areas of limited metastases to hopefully buy time until a patient may go on to develop widespread metastases. And so this concept of oligometastases was defined in the 1990s and has been studied in the 90s and the 2000s. So these are multiple non-randomized trials that were looking at applying the same principles of brain stereotactic radiosurgery to extracerebral metastatic sites. We've already been using stereotactic radiation approaches called stereotactic body radiation therapy already in lungs for primary lung cancers, and it was well tolerated and had very good local control. So why not apply it to metastatic sites that are also present in the lungs potentially from other cancer origins or in any organ? And a lot of these studies found that the local control, so the treated site, actually remained stable, did not show any evidence of progression in 70 to 90% of cases at 2 to 3 years. And so we didn't used to be able to talk about 2 to 3 years in the context of metastatic disease. But now with the advent of multiple new systemic therapies, patients are living much longer. And so this local control is quite important. And these treatments can be quite aggressive in the sense that we're giving very high doses of radiation to small targets. The goal is ablation, so to kill off all the tumor cells in that area. And so with that comes a certain cost, which is that the toxicity associated with these therapies can also be higher. And we typically keep them in the range of 5% or less for it to be considered an acceptable treatment. Now, this has moved on to randomized control trials that have looked at ablative radiotherapy in the oligometastatic setting, and this list is probably growing. I'm going to mention, now these studies have been open to either all comers, like the COMET study, which welcomes patients with many different histologies in many different sites, whereas some of these other studies have focused more on maybe renal cell carcinoma or non-small cell lung cancer. Prostate cancer as well has been a target of oligometastatic trials. I just wanted to focus on this COMET study, which was quite practice-changing or thought-provoking when it was published in 2019. And one of our colleagues is a co-author on the study, having enrolled many patients from our site. So this study looked at randomizing patients that had up to 5 metastatic lesions from any primary tumor site and giving high-dose radiation to focal areas if they were randomized to this stereotactic ablative radiation therapy arm versus palliative radiation therapy only if indicated. So why is this different? Is we only give palliative radiation when patients are symptomatic. So if they have metastatic lesions that are not causing symptoms, we do not offer treatment. But the concept of SABR or SBRT is to treat these sites of disease, try to ablate them so that the patient has no evidence of malignancy in the body, with the hope of delaying onset of new metastases in the future or progression of existing metastases. And the amazing finding from the study was that there was actually an improvement in overall survival. And so that was really quite exciting from our perspective, as well as an improvement in progression-free survival. And so with this, we have been using more and more stereotactic ablative strategies, or SBRT. I'll show you some example of some of the treatments we give in the clinic with a focus on bone mets, although in our center, we are doing stereotactic body radiotherapy to multiple organ sites, brain, some head and neck sites, lung, kidneys, liver, lymph nodes, bone, of course, and I'm sure many others, some soft tissue sites. And so we're really developing this expertise here. So I just wanted to show you some comparison of what like an SBRT would look like compared to a conventional RT. This is what I showed you before about how we've already improved from historical bone met treatments when we give high dose of radiation or high dose 8 gray, the dose that we want to prescribe for palliation that's effective, to a bone site. But you have to be careful when radiation oncologists show you images with color, because it all depends on what we decide to show you. So here I'm showing you where I wanted the prescribed dose to go. But that's not the only place where the radiation dose is going. The radiation dose is actually going in a much wider area of the body, but at much lower concentration. So while I wanted to give 8 gray here, what you're seeing at the outskirts is 2 gray with a gradient in between. Now that's 25% of my dose. When we look at stereotactic doses, we're giving much higher than 8 gray. We're able to shape the radiation very closely to our target, or where we want the radiation to go, while protecting the tissues that we want to protect from high doses of radiation, where the radiation could be irreversibly toxic, such as the spinal cord. Okay, sometimes in the heart, we want to make sure that we minimize as much as possible the radiation dose to the heart. So what this technique allows us to do is to give very, very high doses to specific areas while protecting the spinal cord in these cases from getting that high dose radiation, allowing it to have a minimal acceptable risk. Now, something that's more new in our field is that ablative radiotherapy, or using this high dose to small volumes, is now starting to be used for indications outside of oligometastatic or oligoprogressive sites, where oligoprogressive meaning that a patient is having progression of their metastatic disease, but only in one place or few places. Many randomized studies have shown that there is no benefit to giving higher doses of radiation for pain control in bone metastases up until last year. And last year, a very important and well-designed Canadian study looked at using the technology of stereotactic ablative radiation to treat painful sites of bony metastases, so regardless of the extent of metastatic disease, compared to a more conventional course of external beam radiation. And what this study found was that stereotactic body radiotherapy had higher and significant rates of complete and partial pain response at 3 and 6 months following their treatment. And this is very interesting because this has not been shown conclusively before. And so now this has really extended the indication of giving high dose stereotactic ablative radiation to sites of painful bony metastases, even outside of the setting of oligometastatic disease. And why this is exciting is that while we're achieving higher doses, higher rates of control, the patients are not that much inconvenienced. This type of stereotactic body radiotherapy uses only 2 treatments in addition to a CT simulation, which is superior in terms of visits than even a conventional radiotherapy for a complicated bone metastasis, meaning a cord compression or a vertebral compression fracture, which requires 5 visits, 20 gray and 5 fractions. And so this study is definitely aligns itself well with our goals of providing palliative radiation by maximizing patient quality of life while accepting a certain amount of risk. So I hope I've convinced you to some degree that palliative radiotherapy is in effect a new subspecialty of radiation oncology. Previously, all of treatment of metastatic disease was bread and butter. Anyone can do it and still can. It wasn't particularly complex. The treatment plans were easy to organize and very simple. But now things have really changed. There are active clinical trials in metastatic disease, which was not as common in the past. Sometimes deciding whether a case is palliative or curative is it's actually a very fine line. And we don't want to compromise a patient's ability to get a curative intent care by giving them something palliative up front. So we need to be much more careful when we're reviewing a case to make sure that all of the elements is stereotactic body radiotherapy an option in the oligometastatic setting. Are we considering all of the options available for this patient? There's also a very complex management with ongoing systemic therapy, not knowing what's safe to give at the same time, what is the appropriate time interval between the various systemic therapies and radiation treatment. Now, I'm going to shift here to talk about palliative radiation at the MUHC. So right now, how we manage palliative referrals on the inpatient side of things, we have residents that rotate on a monthly basis and are part of our consult team, and they review all of their consults with a staff that actually changes every half day. That was up until 2018, but in 2018 and afterwards, we started to have a shrinking body of radiation residents. You can see here that this is our current group of residents and fellows minus one of our residents who is on maternity leave. And this includes 2 fellows. So we have very few residents right now in radiation oncology. So we're not able to cover our inpatient service while meeting their academic needs. And so right now we also have a dedicated staff that covers our inpatient referrals that rotates on a weekly basis when there is no resident on the service. Outpatient referrals were previously managed with a rapid access clinic that I'll talk about in a little while, which kind of fell apart during COVID. And we're just booked by radiation oncologists depending on their specialty site. So maybe a lung radiation oncologist would receive more referrals for palliative radiation to the lungs or to interest, as some radiation oncologists are more partial to palliative cases and have a higher volume of those. So we did this when our palliative access clinic prompted an audit and a quality improvement initiative that I'll come to in a moment. Now, if anyone has done a quality improvement initiative, you need to have an idea of what your patient volumes are and some baseline data. And this actually can be quite tricky to receive. If anyone has referred patients to radiation oncology, you might have seen this form that accompanies the typical referral page, which gives you an idea about what is the priority of the patients. This was a paper put together by a group of radiation oncology advisors with the Collège des Médecins, and they have indicated which indications should be seen and treated within 1 day, within 3 days, and within 14 days or within 28 days from the time of consultation. And so this was very clearly defined. However, this paper and this guideline was published in 2004, and the field has changed quite dramatically since then. So if we look at our patients who are referred with priority 1 or priority 2, these typically are palliative indications. And so we can track patient volumes based on these priority levels in our systems to get a sense of how many patients we're working with. And I just want to put your attention here to 1 day and 3 days. This is the time that this is like quality indicators that suggest that we should be treating patients with these indications like cord compression, SBC syndrome on the same day as our consultation. And for painful bone metastases or brain mets within 3 days. And these are 3 calendar days. Now, we did a quality improvement initiative where we looked at some of this data, and we looked at the volume of patients we have, particularly with the priority 2, since these were the more straightforward palliative referrals that were not extremely urgent. And we looked at our percentage of patients treated within their delay. And we found that we were not at all meeting the target of the government, which was probably 90% and above treated within 3 days. We were only getting about 40% on average treated within their 3 days. And so we thought we need to do something about that. So this is a high-level process map of radiation delivery, and we analyzed each of the steps of this process in detail. So one of our issues was we had issues with the entire way that the priority levels were designated and the number of days associated with each of those priorities. Treatments now are much more complex and take much longer times to plan than they did previously, and that may not be well reflected in the timeframes. When we look at the consultations, we saw that patients were not being particularly triaged, like they're triaged by the whether there's urgent written on the referral and by the physician who's reviewing them, but it's not a very detailed triage. And so patients were often being seen with a lot of data missing, which prompted further delays. There's multiple steps, So patient as seen in the consultation, they come for their CT simulation. This was often not on the same day, causing delays. The physicians are then required to contour the areas that we want to treat. By the time the contours are available for the physician, they might have no longer been in a clinic where they're available to draw these volumes. They might be at another hospital site. So MD availability to do contours was not lining up necessarily with the time of the CT simulation. So multiple logistical issues. We tried to improve on some of these issues using our PDSA approach and didn't make a lot of progress, unfortunately. And then COVID hit and caused delays. Now, while we were reflecting on all of this and looking at our previous rapid access clinic, we saw that we were just underutilizing our services, not expediting treatments and not getting patients what they felt was important. And so I reflected back on my fellowship at Dana-Farber, where we had a dedicated palliative radiotherapy model composed of a team-based approach, looking at treating patients inpatient and outpatient referrals. Now, many of these programs exist in the world. Canada is actually an innovator of this type of rapid access approach, with Sunnybrook having the oldest clinic. They target outpatients, and they're typically highly selected patients, but there are mixed programs. Some of them have inpatient and outpatient. Some of them are only outpatient. Some are only hospice, and they've published very impressive outcomes. So a dedicated palliative radiotherapy service has positive outcomes with regards to patients, workflows, and healthcare outcomes. So of course, there's the improvement in patient symptoms and patient-reported outcomes, but there's been better access to radiation and other supportive services, decreased wait times, decreased radiation in the 14 days leading to death, enhanced adherence to evidence-based RT practices, reduced ER visits and hospital admissions, shortened hospital length of stay, increased palliative care referrals, and decreased healthcare costs. And something that's important in our academic institution are improved opportunities for education and research. Now we are in the process of designing our own PRT service at the MUHC. Our target population is composed of inpatient and outpatients. Many centers have a primarily outpatient focus, as I said, but when we look at our numbers, we have about 60 patients that are high priority in a period over a 4-week block. And we felt that that could be managed if we take into account if our focus is really to target those higher priority cases using our team-based approach. Now, this number may have to be reevaluated if one physician on our service is going to be sufficient, but that's something that we're going to look at after we pilot. Our main change is to include a radiation therapist and a nurse that are going to be dedicated to this palliative service. That is going to be their occupation while they're at work. And we're making a very strong emphasis on triage to make sure the patients that are scheduled are truly appropriate for palliative radiotherapy and are not eligible for more aggressive palliation like SBRT or other curative approaches. We want to promote prognostication in decision-making and guideline concordant care. We're working on streamlining our processes and integrating patient-reported outcomes. Now, the critical component, as I said here, is the team. One radiation oncologist alone is not going to be able to manage inpatients, outpatients, and 15 new starts of radiation treatment per week. That might not sound like a lot to those of you, but a typical radiation oncologist will see 8 to 10 new consults per week, and that does not include a number of patients actually starting treatment. So what's going to make this whole team work is that they're going to be supported by a clinical nurse who is going to be hired specifically for this team. Now, funding has been found for that nurse, and we're actively searching. Now, the search has been delayed because of COVID, but that posting is live, and we're hoping to be hiring somebody soon. And one of our radiation therapists, this project is being co-run by our radiation therapy manager, who is a therapist by training. And we are looking at designating one of our radiation therapists who typically work at the radiation machine, but they're actually going to be part of this service, interfacing with patients, helping to coordinate care. And so this team, we feel, is going to really be able to allow the radiation oncologist to focus on seeing the patients, planning the treatments, making sure that they're available to get those treatments out on time. And as a group, we'll triage appropriately and prognosticate and decide on the appropriate treatment approach for patients. Now, where do we stand now? We were supposed to pilot this program in September of last year, and then in January. And now we're probably looking at June, just based on staff shortages that I'm sure many of you have been dealing with, but we very much look forward to working with all of you. We're hoping that with this service, we're going to be able to establish better longitudinal relationships and care with the inpatient services, with the emergency, more continuity by having this nurse and radiation therapist on the service. Our radiation oncologist is still going to be a rotating member of the team. However, the radiation oncologist that we're hoping is going to not be equally split with the whole department, but much more heavily focused on perhaps 5 or 6 radiation oncologists with more interest in palliative radiation, so that it's truly a specialized service. So I'm going to end it there and open up the floor for any questions that you might have. And in the meantime, I'm just going to circle back and say that we have our radiation oncology handbook that I put together with my program director when I was a resident, that has now been taken over and put into an app by one of our very talented residents. And if you did ever have a weekend to spare and want to learn about radiation oncology, you can download the beta version of this app. So I'll leave this up here while I handle some questions.
Thank you so much. Really outstanding lecture. Fascinating topic, I think, which is probably new to many of us on this at this conference today. Congratulations for the work you have done, clinically and research-wise, and for the quality initiative. I think that many of us can learn from that quality initiative you did to look at rapid access to this very, very important therapy. So I'll ask people to enter questions in the chat. I do see this is more of a comment than a question. Carolyn Freeman says the most expensive single piece of new equipment by the new hospital.
I think she's referring to our cyber knife.
Yeah. So I guess, what is, like, looking at, costs of everything, in cardiology, we have costs of all our high technology. So is this really a very expensive kind of treatment approach for patients? And one might argue patients who are on, the last stages of their life. Can you comment on that?
There have been a lot of cost effective analyses done for palliative radiotherapy. Single fraction palliative radiotherapy for bone mets, for instance, is extremely inexpensive. It's extremely inexpensive. I mean, in the United States, they can get away on a hospice budget of having single fraction palliative radiotherapy, which is quite challenging to do. Here, our costs of palliative radiotherapy are generally low. Most of our costs come from time on the machine, I would say, as an extrapolation, although I might refer to Dr. Hijal for that. And so the fewer fractions we give of radiation treatment, the more cost saving it is. So I would say that in general, palliative radiotherapy is very cost saving. And even as we transition towards stereotactic ablative treatments, those are also, while technically more complex in terms of planning needs, once you already have the piece of equipment, which we do have, there is a certain cost of maintaining this high level of technology, which is standard. I would say overall cost saving. But I think the SBRT data long-term in the more palliative setting, we're years away from that for now.
Okay. So Dr. Hijal has responded, we're looking at 1 to 2K per person for a single fraction RT, all costs included. So that answers that question. Thank you for that. Tanya, Dr. Padma wants to know, says it was a wonderful, super informative. At which hospitals does the treatment take place?
Okay, so at the MUHC, all radiation treatment takes place at the Glen site in the Cedars Cancer Center. It's a great question. Our service covers referrals from all of the MUHC, but because of the equipment needs, as I mentioned earlier, the logistical and radiation protection and costs, everything is concentrated here at the Cedars Cancer Center. So patients are transported from the Montreal General or from the MNI or other sites or even the Montreal Children's for treatment here at the Glen site.
Okay, question from Dr. Doss. What role does the radiation oncologist on the actual radiation procedure as delivered by the patient to the patient by the technician?
Absolutely. Yeah, I wish I could have spent more time talking about that. So when a patient has a CT simulation, that is a CT scan that's dedicated of the particular body where we're looking to do a treatment. This is not a very high quality diagnostic level CT scan, although sometimes it's very nice. The purpose of that scan is for us to be able to see the tumor or the target area that we would like to treat and define anatomically the area where we want the radiation to go. So the radiation oncologist's role is to define the area where we want the radiation to be delivered to identify what are the organs at risk and limit the doses to those areas, decide on the dose of radiation used. We then have radiation therapists that are specialized in dose calculation that actually calculate the dose, determine the beam angles or arc angles or the technical aspects of how the radiation gets to where it needs to go. Then the radiation oncologist becomes involved again to kind of approve whether we feel that the dose distribution of the radiation is acceptable. And then when it comes to the patient actually receiving the radiation, I liken it to an oncologist prescribing chemotherapy. We're not physically present at the time of the radiation delivery, although sometimes we are if we need to verify that the position is precise enough, like for a stereotactic body treatment. It's the technologists that are actually administering the radiation treatment, much in the way that a nurse administers chemotherapy that's prescribed by an oncologist.
Fantastic. We have 2 minutes left. Dr. Hijal, I don't know if you want to join the conversation. Congratulations really on the work that you are doing as obviously as a team and as a division. And thank you for that wonderful presentation. Tarek, do you want to just say a final words before we close out the meeting?
So maybe I'll thank you very much, Nadia, and a big thank you to Sonia for this really excellent presentation about what we do. Some good news, we're posting for the nurse that's going to join our palliative team next Monday. So the posting will go up. So I really hope that by even the spring, we'll have that palliative radiation oncology team up and running with the goal of making things faster for our patients, seeing consults on the floors and treating them more quickly, but also probably with the goal to educate and inform our colleagues that palliative radiation is often underused and that we can do better to make sure that patients get the best care, especially towards their end of life.
Thank you very much. Thank you, Dr. Skamene, and obviously thank you, Dr. Hijal, and congratulations on the work that you have done and the quality improvement, the quality assurance work you've done, your handbook. There's a lot going on in the Division of Radiation Oncology. So thanks for sharing that with us. And thank you everyone for participating. I wish everyone a great afternoon. Have a great day. Bye-bye. Thanks.
Thank you.